I'm Ben Ryman, and this is Behavior Speak. In this conversation, Dr. Rindee Ashcraft shares her insights on OCD and anxiety treatment, discussing the effectiveness of exposure and response prevention as a primary treatment modality. She emphasizes the importance of understanding OCD symptoms, the role of genetics, and the need for proper training for therapists. Dr. Ashcraft also highlights the significance of community support and the impact of accommodating behaviors on OCD symptoms. This discussion covers various aspects of OCD treatment, including body-focused repetitive behaviors and future directions in therapy. Welcome, Rindee.
Thank you. I'm excited to be here today.
Yeah, grateful to have you. Before we get started, I just want to acknowledge I am producing this podcast on the territories of the Klamath, Kleyu, Somoko, and Comox First Nations, and I'm grateful to be here. So, Rindee, tell me a little bit about yourself.
I am a psychologist just outside of Seattle. I specialize in working with OCD and anxiety and all of the related disorders. So that's the body-focused repetitive behaviors, embodied dysmorphic disorder, and all the variety of anxiety disorders. I have a group practice right outside of Seattle called Polaris Family Behavioral Health. So now I train a bunch of people to do the same thing. And I spend a lot of time talking about OCD and all of its disorders and just educating people, and really love talking about and advocating for treatment of OCD and anxiety with a wide variety of age groups. And yeah, I enjoy it quite a lot.
How'd you get into this work?
It was actually completely accidental. When I was going through grad school, I was going to work in the forensic realm. My first graduate degree is a forensic psych degree. And then I ended up doing trauma work and was really enjoying that. And a colleague said, you know what you need to try? Because you will love this. You need to try working with OCD. You love working with kids. You got to try OCD. And she sent me a case, and I've never looked back. I've never had so much fun as I do when I'm working with OCD, both because the therapy is just interesting and entertaining and never what I will expect, and because when I'm doing this work, I get to see people feel better, sometimes really fast. Not always, but the primary treatment modality I use is exposure and response prevention. And somewhere between 70-75% of folks respond to ERP. And that's a phenomenal response rate. Sorry, my dog's very attention excited right now.
Yeah.
When you're doing something and you see people get better, sometimes really fast, and you're having fun with what you do, and you're seeing the people you work with have fun, it's just everything about that was just a great fit for me. And I haven't looked back.
Is that sort of unique to OCD in that the treatment works so well? Is that not common in a lot of these sort of psychiatric disorders that folks are working with?
I think that there are other treatments that also work fairly well. And I think there's a lot of exposure-based works, actually, that tend to be pretty effective. And there's a lot of other treatments that can be fairly effective. And there's a lot of treatments that it takes a long time to see progress. And sometimes the progress you see it's not as notable. So when I was doing trauma work, yeah, we absolutely saw progress, and sometimes potentially even the same percentage of people. The thing about OCD that can be different is that typically people with OCD, they know that what's going on it's not something they like. It's not something, that with OCD, the fears that they have or the distress, their obsessions are typically not something, they know it's not rational the vast majority of the time.
Got it.
And they know that what they're doing about those fears or the thing that distresses them, they know it doesn't make sense as well. Not always, again, of course, but when you are able to step in and have this treatment, you're helping take away something that can be so much bigger. That's probably the wrong word, but that just is how it feels because OCD can be so disabling. It can be so disabling. And so it feels like you are making a bigger difference faster. And that's just incredibly rewarding.
And so do you find that then that for the most part makes your clients sort of, because I know a lot of folks struggle with just getting clients to want to participate in treatment. And do you find that that's not as big of an issue for you?
It can absolutely still be an issue. When we are doing exposure-based work, it has a bad name. When people develop, it's researchers who develop the names of the therapy, and exposure and response prevention is not a particularly exciting name. It doesn't sound razzle-dazzle. The marketing's not good, right? So it doesn't sound great. And the idea of going out and doing the thing that terrifies you, it can still be really hard because even though it doesn't make sense, there's a part of your brain that definitely says, for example, if I flip this light switch, it will kill my parents. And that's a big risk. So on the one hand, they know it doesn't make sense. And on the other hand, the risk can be so high and it can be so scary that the motivation can still be something we have to work with.
Yeah. So maybe a little bit on sort of what is OCD? What makes something OCD versus me just doing something a few times or doing something, or sometimes I'm a pretty forgetful guy. I think that kind of goes hand in hand with having ADHD, and so what makes me just being unsure if I turn the stove off versus someone else who's got something diagnosable? What makes one have OCD?
There's a few different things we tend to look at when we are looking at OCD. A big question is, what happens if you don't do it? If you have a routine when you leave of just like, checking around the house. Did I remember to turn off the stove? Did I remember to lock the back door? Whatever. What happens if you don't follow that routine? Does that cause a lot of really intense feelings of distress? Or does your brain say, whatever, it's probably fine, not a big deal? If it causes a lot of really intense distress, it's more likely to fall into the OCD world. And then also we look at time. If it causes a lot of intense distress and it takes a lot of time out of your day, by which we mean more than an hour, and we're probably looking in the OCD world. And of course, as with every diagnosis, it's got to get in the way of functioning.
And so once someone gets that diagnosis, is what's usually the next step? Do they usually come to someone like you for this type of therapy, or are they prescribed medication, or what direction are they sent typically when they find out there?
Well, unfortunately, OCD, getting that diagnosis is hard. OCD is one of those diagnoses that recently people have started to learn more about, which is amazing. But that's relatively new. But once people get that, what's the ideal? Then, potentially they're getting meds, they're coming to see someone like me, they're getting treatment, and they're off and running. That's not actually what normally happens. Normally what happens is I think we're down to an average of a 9 to 12 year delay between onset of symptoms and getting appropriate treatment. It's OCD can be debilitating. I mentioned the 1 hour. And it can take up your entire life. It can be 12 to 24 hours. People wake up with nightmares. It can be pretty bad. So, and ideally, there's people like me in lots of places. And so it's easy to find someone like me, but that's not necessarily true. So often people go and get medication and then hopefully can find someone like me. But sometimes it's a little bit harder to find someone who's appropriately trained. And unfortunately, OCD is something where if you go to a therapist who is not appropriately trained, normal cognitive behavioral therapy can make OCD worse.
Wow.
Because if you are introducing the normal relaxation skills, those can become rituals and can really be problematic in the OCD cycle, which is not ideal. And certainly not what any therapist is intending to have happen. But if you have a therapist who has not been educated in how to treat OCD, they just don't know any better because the education just isn't something that is provided in most grad schools about how to appropriately treat OCD because it's relatively new that we figured out what to do. So it's no one's fault. It just is.
Can you give me an example of how that might happen? So if someone's being taught some relaxation techniques, how that would then turn into a problem?
So the normal OCD cycle of, let's say a normal OCD fear for an adult could be a stereotype is germs. Someone gets really uncomfortable with germs because they don't want to make other people sick. So they're really careful about germs. They don't want to make other people sick. So they wash a lot. They wash their hands a lot. And this is getting in their way because they're washing their hands too often. Now, they're going to have a lot of other rituals because OCD doesn't typically just target one thing. But for this example, let's stick with that one. If they go to a regular therapist, that therapist is going to absolutely see this person's really anxious because they are. There's a lot of anxiety that's happening because they don't want to make other people sick. They're terrified they're going to make other people sick. Of course they are. That sounds awful. Who wants to make a bunch of other people sick? And so they might say, hey, before you wash your hands, why don't you practice some deep breathing or use some muscle relaxation? OCD doesn't actually care what your ritual is. It's happy to add rituals. It's very happy to say, oh, so we're going to do deep breathing and wash hands? That's fine. I don't care. We're going to do muscle relaxation and wash hands? Sure. We'll make the ritual longer. No problem. That's totally fine. And so now you've got two parts of the ritual. And so what was just a hand washing ritual is now a relaxation and a hand washing ritual. Or let's say you struggle with falling asleep. And so, which you have OCD about sleeping perfectly. If you don't sleep perfectly, you're going to have a bad day the next day, which many of us have been told forever. We need to have a good night's sleep.
Right.
That's a really normal thing for OCD to develop. You go to a therapist who says, hey, mindfulness. You should do some mindfulness videos, mindfulness breathing. Do that for 20 minutes before you go to bed. It's going to be great. You'll sleep better. No problem. The problem with OCD is that it's going to say, excellent, but you have to do that 20 minutes of mindfulness perfectly. But how do you do mindfulness meditation perfectly? That's really hard to do. And how do you measure that? And to do the OCD ritual perfectly, then you do the mindfulness meditation. But then somewhere in the middle, you might have a thought wander in because our brains have thoughts wander in. And then, well, that means obviously you have to restart. So you go back and you start again. And then you're a little bit more anxious because you're restarting and it's getting later and your sleep is going to be more disturbed. And so you start again, but another thought wanders in. And so you have to go back and restart. And this cycle repeats over and over because OCD is telling you that this mindfulness meditation has to be done perfectly. And that's so challenging. And so all of a sudden, this practice that if you don't have OCD can be incredibly helpful for helping people fall asleep at night and sleep more deeply. It's a great relaxation technique and a great way to sleep better if you don't have OCD interfering with it really can get in the way if you have OCD interfering with it.
That makes a lot of sense. And then, of course, doesn't.
Right? But that's the thing about OCD is that it
Yeah.
has this way of distorting logic that makes it not act like normal logic.
I definitely want to spend a good chunk of time talking about the therapy modality, but I'd like to ask a few questions about, first off, do we know much about sort of what causes OCD and or things folks might be able to do to kind of prevent OCD?
We know that genetics causes like 45 to 60% of OCD. And we know OCD's been around it happens, it's across race, it's been around. Like if you look back, there are documented descriptions of OCD that look almost exactly like the OCD we have now, going back like 1,000 years.
Wow.
So it's really, that genetic piece is pretty solid. For prevention, it's tricky. There aren't necessarily great ways to say prevent it. Are there things that people can do to limit the chance that they will have it be a huge problem in their life? Absolutely. We talk about living the exposure lifestyle. Can end up being kind of fun too. It means that you allow yourself to build risk into your life. So you let yourself do things that might terrify you. The idea of speaking on a podcast is terrifying to me. So I am here today because taking risk is an important thing for me to be doing.
Right.
But it doesn't have to be huge risks like that. It can be little risks like wearing your hair differently or wearing an item of clothing that's a little bit outside what you would normally wear. Or, we talk with kids and teens, we talk about smiling at someone in the hall that you wouldn't normally smile at, or trying a new food that you wouldn't normally try. Like, these don't have to be huge risks that you're taking. We're not talking bungee jumping, right? It's just trying something new and building that into your life as a regular, normal part of your life.
Sure. Yeah, that makes sense.
It doesn't prevent it, but it does make it easier to fight should you need to.
I'm thinking about sort of the bungee jumpers and, the X Games kids and things like that. Are these folks, do we know if sort of folks like this are maybe correlated with sort of lower incidences of OCD, or is there any relationship there? Do you know?
Actually, I don't know. I do know that when I was little, there was a show called Double Dare that's similar to Fear Factor.
Sure.
The host had OCD. And it really was all about doing gross things. So do we know? No, because typically the OCD is not going to target, it doesn't necessarily target the stuff that's easy for you to do. So if that's something that you already do, honestly, I think it just makes it easier to fight if it pops up. If that's something that's already in your skill set.
And where does medication fit into OCD treatment?
Medication can be a huge added treatment modality. There are some amazing meds. Typically, SSRIs are the first line of med treatment. It is, if you have OCD, it's really important to make sure you're doing your own research on dosage, because typically for SSRIs, the dosage is a little bit different than when you're being treated for other things. And so it's really important that you're able to advocate for yourself, because sometimes, unfortunately, the education hasn't necessarily caught up with what the research on how it should be prescribed, if that makes sense. So we know that SSRIs are really effective, but we also know that in order for them to be effective for OCD, they typically need to be prescribed at much higher doses than they would typically be for other things. And sometimes prescribers haven't had the opportunity to learn that yet, because again, the education just hasn't caught up. So it's really important to just make sure you educate yourself.
Yeah. You talked about sort of this sort of stereotypical OCD and some of the things I think the movies and other places have talked about, and the washing the hands, the checking, that sort of thing. What are some other kinds of ways that OCD presents that folks might not be aware of and maybe not even realize are part of that OCD spectrum?
That's such a great question, because those stereotypes are actually not the most common ways that OCD presents. Much more common are what I was hinting at earlier, that this idea that you might hurt someone else.
Mm.
We call it like aggression is kind of how it gets looked at, where you might hurt yourself, where you might hurt someone else, either physically, you might hurt their feelings, you might accidentally insult them. And that fear that you could potentially hurt someone can be so terrifying, because if you really value not hurting people, that really pokes. Really. And that's the thing, is OCD does tend to find a value and make that thing the thing that you are most scared of. Yeah. Um, so we do, in fact, even find that there are some folks who it's a fear that they might accidentally kill themselves. They're not suicidal, but they might have a fear that they might kill themselves. Right now we're hearing a lot about orthorexia, which is not quite OCD, but it's in that same vein. It's almost OCD about food, where people have a really strong obsession about how they're eating and what their food needs to do. So they want to make sure that there's no contaminants in their food, no chemicals in their food. And it's the same type of thing where, most of us, it makes sense that we want our food to be good food. We want our food to be healthy food. If you find that that is restricting you to the point where you can't eat other things and it's hurting you, it's an eating disorder that is certainly more present now than it has been in a really long time, and more present at older populations. It's similar. It's used to be ARFID. Now we're seeing functionally ARFID in older people. By which I mean adults. Other really common OCD themes are this idea of things needing to be just right and feeling just right. But how do you measure what just right is? You can't. It can be very challenging because of not having what we call a core fear. You just know that things feel wrong. And if it feels wrong, you can't do it. And having to explain to people, well, I know I can't read that book. I can't tell you why. A lot of people have probably heard over the years at some point about scrupulosity, or a fear that you might offend religion, that you have to follow religion to a specific degree.
Right.
Falling within that is the idea that things have to be really fair, or that you have to be really moral, even if it's not necessarily religious. We're also seeing a lot of health anxiety, which can absolutely end up being OCD, where you do a lot of checking. What symptoms do I have? And is that OCD? And so going back to the doctor over and over again to check. Are you sure it's not this? Is it that? Could it be that? And doing a lot of body scanning. But I see this. Is it there? Yeah, those are some examples, and there's so many more. OCD can target anything you care about.
I'd like to take a minute just to talk a little bit more about the aggression one, because I think just to sort of maybe dispel some fears folks have about, even trying to get that treated. Because, I think it's easy to go into a clinician and go checking things, or, I'm not sure about things, or I'm trying to get things just perfect here and there. But it's probably harder to go to a clinician and go, I'm having thoughts of hurting people. And you had suggested to me before the interview that I should check out Maria Bamford's keynotes, and I checked out the shorter one, and it was during COVID, I think, and if folks aren't familiar with just the comedy of Maria Bamford, she's awesome, but she has some great anecdotes and really tells the story really well. She talks about this Harm OCD, and so then I started Googling like Maria does in the keynote and realized this was a thing.
No. So there's two pieces to that. So the first one is they've actually done research on the how many of us have those thoughts, those that like flash through our brains, and like the driving off the bridge one, or the like mine tend to be like when I'm driving down the road and like, and you see like that divider. And so that's one of mine. Like, can I actually do it? And of course I'm not, but thoughts like that are like, oh, and especially for new moms, if you're going to throw your kid down the stairs, if you're going to throw your kid off a bridge, 95% of people have these. And the researchers concluded the other 5% were lying. They're so incredibly common. Our thoughts are made up of electricity and chemicals shooting up and down our brains. And kind of like at night when our muscles twitch and we just can't control it, sometimes our thoughts do the same thing. It's just not they don't mean anything. It's just muscles, or it's just chemicals and electricity that shoot through our brain, because there are so many different pathways in our brain, and everyone has those thoughts happening. The thing about OCD is that when that happens and it's about something you value, OCD attaches meaning. And so OCD says, you're terrible. And there's some other disorders where you also may attach meaning as well. But OCD absolutely attaches meaning, says you're terrible, and attaches all kinds of rituals that prevent you from driving off the bridge. And often the rituals don't make sense. So you might, in order to make sure you don't drive off a bridge or throw your kid over the side of the bridge, you might do who knows what. I've heard some very I've heard many, many different rituals, because the rituals sometimes absolutely are connected. Like before you get in, you just checked in with someone so that they know, hey, I should be here by about this time, so that if you don't get there by about that time, someone will know. Which, that kind of makes sense. It's a little connected. Or it's a little dance before you get in the car. Why is that connected? It's not. It's just that our brain puts things together. Part of the advantage of talking with an OCD therapist is if you have a fear that you might accidentally stab someone, not a desire to stab someone, but a fear that you might, we totally understand that. We've absolutely heard that before. That's not a fear that's going to bother any kind of OCD therapist, because it's a really normal OCD fear, super normal. If you have a fear that you might accidentally kill yourself, it's so scary to have that fear. And that's a really normal OCD fear, which doesn't make it less scary, but does mean that it's okay to talk about it to your OCD therapist, if that makes sense.
Well, and it really speaks to the importance of training that you're talking about, and being trained, because the fear of killing myself could really start a chain of events that ends where I end up spending 10 days in a hospital within moments, because the untrained therapist is reporting me, he's talking about suicide, we got to put him under a watch, all that sort of chain of events can occur quite quickly if the therapist, and also probably have that person never go back to a therapist again.
Absolutely. Right. For something where you were never wanting to kill yourself. There's never a desire to actually do it. And it gets extra complicated because it does happen where sometimes, OCD is hard. OCD is debilitating. And sometimes it's so heavy that there are thoughts of wanting to kill yourself where you really do sometimes just, you don't know if you can do it. And you have the fear of doing it. And so being able to talk with someone who's trained to like tease all of that out, and able to say, we can give you coping skills because you're not going to, or this is when it is time to go to the hospital, as opposed to someone who doesn't understand where the nuance is. It's important.
So let's talk about the exposure therapy. So maybe a little bit about, you said this is sort of a relatively new therapy for OCD. So how did this become, what is it, and how did this become a treatment for OCD?
So exposure therapy is relatively new. And I should say, so exposure therapy probably is 35, 40 years old. And probably, at least in my area, in the last 10 years, the number of people, I'm down in Seattle, probably in the last 10 years, the number of people who are trained in it has tripled. And it's kind of exciting. This is a time when there are more treatments for OCD that are being researched. This is a very exciting time to get treatment for OCD because there are more options than there were. There's something called ICBT, which if exposure therapy doesn't work, it's a type of cognitive therapy that can also be helpful. I tend to prefer exposure therapy because I think it's a lot of fun and I really like to have fun in therapy. And frankly, OCD hates to be laughed at. I'm a fan of doing things OCD doesn't like because OCD takes away a lot from people. And so I'm good with laughing at it. Yeah, I'm really good with laughing at it. And I forgot your original question. So go back to that, please.
Yeah, just sort of, you kind of answered the first part about when folks started using it. The second part was, what is it?
So functionally, what happens is we figure out a couple of different things. We figure out what a person's core fear is. We figure out what they're doing to avoid the core fear. And we figure out all of the pieces in between. Then we find ways to do it. So we've been talking about aggression and fear that you might kill yourself. If that's part of the fear, and if the core fear is, let's say, that people don't see you, that no one will notice if you were not here, then we would come up with a list of different exposures that would include playing with knives. We have a whole bunch of big knives at the office. That would include taking knives and rubbing them all over arms, putting them wherever you're concerned you might accidentally stab yourself. We would put them all over our bodies in those areas. We would, depending on how hard that is, we would draw knives. We might, again, depending on how hard these things are, we might just say the word knife. Depending, again, on how hard things are, we might just start with the letter K. We might write a suicide note. We might plan a funeral.
Wow.
We very likely would do some research on customs around death and what different customs for death look like in different parts of the world, and just lots of different ways of looking at death and suicide for this person. We also, because the core fear is not being seen, would encourage, as best we could, taking steps to be seen a little bit more. If that means being more social, that means, depending on where they are, I work with a lot of kids and teens. If that means talking in class a little bit more, if that means inviting friends over a little bit more, if the person's an adult, if that means talking with your boss a little bit more, if that means going to more social groups, spending time outside of the house, doing classes, whatever kind of event you can that you are with people more so they will see you. And with all of these, we're going to do these without whatever safety rituals were the compulsions. There's several keys to whatever we do with exposures because those sound scary. It's always with consent. This is never something that gets forced on people because that doesn't make sense. If we can, we're going to make it fun. So yeah, we're going to play with knives. We're probably going to at some point be cutting up chocolate and eating it, because chocolate's delicious. And that's a really good way to be comfortable with knives, is to be using them in a way that brings pleasure. We're probably going to, at some point, be watching some knife skill building videos. And again, absolutely, this is never something forced on anyone. This is always with consent. If the person says no, we're going to say okay. Because it's not fair, it's not reasonable for them to be doing exposures that our goal is for them to come back and do it again, right? Our goal is for them to get better, not for them to have a panic attack and not come back. So we really work hard to make sure that, yeah, we're absolutely doing hard things, but we're doing hard things that they are engaged with, that they are excited about-ish, and that they are sitting with that knife at their wrist long enough that it gets a little bit boring, because you would be surprised if you don't actually want to kill yourself and you take a knife and you put it at your wrist and you sit there for 10 minutes, it starts to get a little bit boring for most people. And then all of a sudden, like, you start wanting to talk about something that is not the knife at your wrist.
Right.
And then we get to start saying, wow, look at you. Look at what you can do. And you didn't realize it. It's exciting.
That's amazing.
Yeah.
Another area you talked about that you have a lot of interest in are some of these kind of body-focused disorders and body-focused repetitive disorders. And that makes me think about something we run into a lot in behavior analysis. So maybe we run into all these things. But one thing in particular that we always seem to kind of hit a wall with is skin picking.
Yep.
And
hair pulling. And nose picking.
Yeah.
Yeah. And maybe biting nails.
Right.
Right. And biting the skin next to the nails.
The cuticles and the
Yep. And maybe even picking scabs.
Yep.
Yeah. All of those. Yeah.
So how does that fit into OCD? Is there, like, how do you kind of conceptualize a skin picking, and then how do you go about treating skin picking?
So the body focused repetitive behaviors are considered like a cousin of OCD.
Mm-hmm.
And the thing about them that's true, there's lots of different reasons why people do them. But for many people, one of the reasons why people do them, not one of the reasons, there's others, but one of the reasons why people do them is because it's a coping skill. If you feel bad and you pick at your skin, you feel better. It's not a healthy coping skill, but it is a coping skill. So certainly when we're treating them, because it is a coping skill, it makes them tricky.
Mm-hmm.
When we are treating them, the first thing we want to do is a functional analysis. Why are people picking? Right. Is that the reason?
Yeah.
There's others as well. It can look like OCD. It can look like, well, I have to pick at this because it feels wrong and it has to feel right, which can be very much an OCD thing. It can also be I have a sensation, and the sensation means I have to pick. So knowing that piece obviously changes the treatment. But for many people, I feel bad, and so I will pick. If that's the case, we work really hard to introduce a lot of other possible alternate coping skills that can be hopefully as effective at reducing whatever feelings that coping skill was alleviating, and ideally helping a person start to use them beforehand. It's tricky though, because there is something about skin picking on any of the body focused repetitive behaviors that you just feel good after them. You feel shame later, or many people feel shame later, but immediately after, you feel good. You feel relief. So we work really hard to find coping skills that can almost parallel those as close as possible. So a lot of our parallel coping skills, like if there's hair, we have, those balls that have like all the hair things that come out.
Yeah.
We really love those, like koosh balls, I think they are. We have lots of koosh balls, wiki sticks for skin picking. We really love like glue on the hand, or there's others that are almost like similar to picking things. And then we really work hard to raise awareness, because some people pick and they don't even notice, because it's just it becomes habitual. And we raise awareness by using things like Band-Aids. Not everywhere, but a Band-Aid on whatever you pick with, because most people have a specific finger, for example, they pick with. So you notice, I was about to pick with my finger, but there's a Band-Aid there, so I can't. That's a reminder. I'm going to go use this other coping skill instead. And very often, I'm definitely a behaviorist, so we'll try and pair that with positive reinforcement. If you are able to replace that coping skill X number of times, you get some kind of reward, because, yay, you did it. It can be really, really hard to fully change that, because it does have the immediate, it feels good when you pick. even though there is shame later.
When you talked about sometimes it's not about coping, that it's just about this physical sensation, is that a different approach then?
Yes, and actually frequently it's multiple. Frequently it's like all three. So we want the coping for one, and then if it's the sensation, we practice sitting with the sensation. So we will practice in session making yourself itch because it's, our brain is so powerful. Phenomenal. You can make your ear itch if you think about your ear itching, or you can make whatever part of your body have a sensation where you want to pick or pull. And then you make a different part of your body have that sensation to kind of help relearn how much control you have. And you practice having that without picking. Very obviously, very exposure based, but sitting with that sensation and not picking. And we absolutely, because one of the things that can happen is once you start picking, the skin needs to heal and you have more of those sensations. And so we work really hard to not pick for a while so the skin can heal.
Yeah.
It can be really hard to sit with that sensation though and not pick while it heals.
Yes.
Yeah. But it's worth trying. Yeah.
I'm smiling because the moment you said itch, that one
Right?
spot in the center of my back got itchy where I cannot reach and don't want to try right now. But yeah, it's easy.
Well, and I said your ear itches, and of course my ear started to itch.
Of course, yeah.
Right.
I wanted to ask a little bit about, because a lot of my listeners are behavior analysts and a lot of my listeners work with folks with intellectual disabilities, often folks that are non-vocal, aren't speaking, and a couple things come up. One, I think, is sometimes maybe a bit of confusion, and this isn't so much the behavior analyst issue, probably more the diagnostician around sort of deciding whether it's OCD or repetitive behavior. Any thoughts on that?
It's so funny because generally speaking, OCD is incredibly underdiagnosed, except for one population. That would be folks with autism. That would be the only place where it's overdiagnosed. And of course, you can also have both. And so when I think about repetitive behaviors, I tend to think about it in terms of if there's a repetitive behavior and it's both OCD and autism, how do you know which is that specific behavior? I go back to the original, how do you know if it's OCD question? Why is the person doing the behavior? Are they doing the behavior to stop a distressing thought? Are they doing the behavior because it's... So I've worked with a number of folks who have both, and they often will have repetitive behaviors that are typically, the family describe them as play or pleasant, pleasurable. And that may not be how most of the listeners end up describing their repetitive behaviors. That's how it's frequently been described to me. And that repetitive behavior it's not done to get rid of a fear. It's done because the person likes it. It's done because if they couldn't do it, it's not that they would be anxious, they would be sad because that's their fun time, or their, I kind of think about it as like most kids enjoy quality time doing something pleasant for themselves, and they can delay it and it's not a big deal, but at some point in the day they want to do it. The when matters less. But if it's OCD, the when really matters. Is this making sense?
So I think the dilemma that I've run into a lot in the past is around treatment, and in particular with these folks that aren't able to speak to us. Have you had any experience in that area?
I've consulted with some folks who are nonverbal. Oh no, and I've treated some folks who are nonverbal. The treatment isn't really all that different. There's a couple of different things we can do. So the first one is if you have a really good idea that what you're looking at is an OCD behavior, one of the things that often happens when someone has OCD or anxiety is that the people around them change their behaviors so that person doesn't feel anxious or uncomfortable. So For example, you might find that you have someone who they have no food issues, but when the food touches, it makes the kid uncomfortable. And so the parents plate the food on 3 plates because they don't want the kid to be uncomfortable. We call that behavior accommodating. When we have a kid who doesn't have motivation or who isn't verbal, that's typically the route we take, is gently removing the accommodation. And depending on where they're at in terms of how impaired they are and how sick they are, we'll do it slowly, but we will just move towards the food on 1 plate.
Yeah.
Because if there's not a reason for the food to be on 3 plates other than them being anxious about it, telling a kid that they can't handle an emotion doesn't help the kid. It typically just hurts them. And it's useful for kids to know that their parents believe they can handle feelings. And yeah, that we actually end up doing a lot of work with families to remove those accommodations. That tends to be a pretty important part of treatment.
Because I was thinking about sort of, the exposure work and how you need that consent piece.
And what ends up happening is you're not changing. You are certainly telling the kid, and you may not be having the food touch, but you're not giving 3 plates. And we definitely try to work to make sure that when we remove accommodation, so for example, with 3 plates as an example, we probably wouldn't go straight to all the food on 1 plate and it's touching. That's a huge jump. And we probably would want to make sure that that kid could get up and could get another plate if they need to. We want to make sure that we can find a balance so that the kid can get their own second plate if they need to in this example.
Yes.
But the parents aren't getting the second plate. The parents aren't forcing anything, but the parents are changing their behavior. They're not forcing anything. They're just not.
I like that.
Yeah, because it's okay for the kid to not have food touch. That's absolutely fine. However, the parent doesn't need to make it easy.
Yeah, it almost seems like in some of those cases, some of the obsessive behavior is on the part of the parents. They may have put in really rigid restrictions or accommodations for things that may have been a little over the top and could probably fade back to something and still have some success.
And the parents, they worry. Their kids, they've seen their kids struggle with emotion. My house is not on fire, never fear.
Excellent.
And over time, small changes get bigger and bigger and bigger. And kind of like we shape behavior for more positive gains, their behavior has been shaped. So now there's 3 plates.
Of course.
So we're just trying to go the other way. The thing that happens, though, is the parents have inadvertently communicated to the kid that they don't think that the kid can handle 1 plate.
Right.
And of course, that's not the intention, but that is what's being communicated.
Yeah. I mean, it sounds like there can be a lot done with assent.
Right.
When consent maybe can't be given because they don't speak or write or whatever or read. Yeah. Because I'm thinking less about children. We work a lot with adults and who have been kind of displaying these OCD type behaviors for decades.
We do the same protocol with adults.
And what happens is it's not what you're calling accommodations have now turned into kind of full on restrictions and restrictive practices and, locking things up and limiting access to things. Something I've seen a lot in some of these sort of group home kind of contexts are these sort of, what's the term they use? There's a term for it, but sanitized or whatever, but essentially rooms that have nothing in them at all.
Yeah.
In order to prevent folks from moving dangerous things or whatever and so on.
And we put it all under the umbrella of accommodation. It is accommodating the individual's anxiety or OCD.
Yeah.
And absolutely, I talk about it typically related to kids and teens. And it's absolutely not just kids and teens. It's any family member who has anxiety or OCD can be accommodated. And actually, one of the biggest predictor of anxiety or OCD not getting better is how much their behavior is accommodated.
Wow.
So we work really, really hard to help reduce that because we're pretty passionate about people getting better.
Yeah. Well, let's shift over to sort of training. So you've been spending a lot of time in your practice trying to get more folks kind of educated in how to work with OCD. So and you said that sort of typically folks that are maybe getting training to be psychologists don't get this training in university. And so I guess number one, is that changing? And two, if not, how does one become specialized in OCD, or what's involved there?
I don't know if if that is changing a ton. I hope it is. I think there are certainly more education specific opportunities like internships and postdocs, etc.
Right.
that are OCD specific, and that has definitely changed. And we're just talking about OCD more. That has definitely changed in really exciting ways. There are so many more therapists who specialize in OCD than I only started doing this 15 years ago in the Seattle area. And there are so many more OCD specific therapists in our area now. It is phenomenal. But I didn't get trained in grad school. I did it all after grad school. So it's not necessary to do it in grad school. It would be lovely if, we got the training there, but it's definitely possible outside of grad school. The most ideal way to do it is to go through the International OCD Foundation. They have a Behavioral Training Institute, which has just a phenomenal training program. Unfortunately, there's like a 3-year wait list for that.
Wow.
So that's not how most people go. There are other training programs that people have found online that people are using. And honestly, the community of OCD therapists, once you get into it, is just wonderful. They're just delightful. The OCD conference that happens every year, it's in Chicago this year, is probably the nicest group of clinicians you will ever meet. It's the best conference people go to. It has clinicians, it has researchers, it has adult clients, it has families, everyone at one conference. And because it's still a relatively small community, it's just nice. Everyone still really knows each other. People are just nice. It's really lovely. I really love the community and once you are trained, it's really easy to reach out and say, I have questions. Can you help me?
Is it typically psychologists doing this work, or are there folks from different disciplines?
All kinds of different disciplines. Probably mostly a lot of master's level folks. I feel like in the field, there's a lot of master's level folks doing the work, just because there are more master's level clinicians generally. And a lot of master's level people do amazing work. There are definitely a lot of psychologists doing the work as well. And we obviously do pretty good work too, but there's also just a ton of master's level clinicians doing really good work. It seems pretty broad. Yeah, that's pretty great.
So what's next for you in your practice and goals for the future?
So actually, we're really excited. We are doing a lot of new things right now. One of the things that our practice is really focused on is building community and trying to try new things and see where it takes us. So we are putting together a summer intensive for kids.
Cool.
Where it's 1 week where people come and spend a week working with other kids to do a lot of exposures and hopefully leave feeling better. And we're also starting a couple of different support groups where we don't have a lot of support groups. Seattle is a funny place where one side of the lake has a bunch of support groups, the other doesn't. We're starting support groups. We're starting a social anxiety support group and an OCD support group, which is exciting. And we are also getting ready to start a couple of community nights. So like an art night or a poetry night, where people can come and do OCD art or OCD poetry and then share it. And we're
Cool.
really excited about those things and just have it be about the community. Yeah,
Take away the stigma.
that's absolutely the goal. We want to make the community, it is a great community nationwide. And so having people get to enjoy that just in the Northwest is great. So we're excited to see where that goes.
Awesome. I can see how much you love this work, Rindee.
I mean, it's really hard not to once you get started. It's such great work, great people. It's really fun.
Thanks for sharing so much about OCD with us. Appreciate it.
Thanks for having me. I really appreciate it.
If you enjoyed this conversation, there are 2 other episodes of Behavior Speak that I think you might find interesting. Check out episode 39, Behavior Therapy for Tics and Tourette Syndrome, with Dr. Douglas Woods, and episode 199, Behavior Analysis and Prader-Willi Syndrome, with Dr. Casey Bedard. If you enjoyed this episode, please consider leaving a review on Apple Podcasts, Spotify, or wherever you get your podcasts. And please follow us on Instagram @BehaviorSpeak.